Good morning. Thank you for coming, and thank you for inviting me, and thanks to the Reverse Rett Foundation for inviting me. It is a real pleasure. I come from Chicago, and this is my hospital. In the background, you can see the Chicago skyline. So this was a commercial for my city, and the Pope comes from the same place. So in next, it's been 90 minutes or so, I'm going to cover what's the normal breathing, what is its mechanism, what are the factors which affect it, and what are the consequences of abnormal breathing, and what kind of abnormalities and the complications because of the abnormalities we see in patients with Rett syndrome. And then, of course, what are the strategies and techniques which are available to us in order to take care of these patients. And then, of course, briefly I'll touch on the comorbidities which directly or indirectly affect the breathing also, such as swallowing issues or reflux, etc. So before I go ahead, I want to put a disclaimer that I am not a neurologist, and I'm not involved in the diagnosis of the disease. But then, of course, I'm part of the team, and I get referrals from all over the place in order to take care of the pulmonary problems in the patient. And then, of course, I need to emphasize the point that respiratory problems, as you have seen, you heard yesterday, they're not the top of the list in terms of the people being worried about. Having said that, they are there and they play a significant role, and every patient is different. It's not that because what I am going to describe to you may sound that, oh my God, this is going to happen to my child. No, that may not happen, and that will not happen. Very rare. But in order to make you understand, I have to kind of go to the mild to actually severe extent so that you understand what happens in these patients. So when we talk about the normal breathing, we are breathing 20,000 times per day, and which translates into 8 million breaths per year. So each time we breathe, we are processing around 4,000 gallons or 440 cubic feet of air in our lungs. So this is, in fact, I should go. This is, you see the windpipe or the trachea, which divides. So windpipe here, trachea, windpipe divides like a branches of a tree. Like supposing my neck is one arm of the airways, arms further branches, my fingers further branches. So when I'm breathing in, air is coming through my nose, mouth, into the windpipe, goes to the airways. At the end, when my nail was, that's where the air exchange, and we're going to expand on that in a minute. So the breathing is basically breathing in and breathing out. And breathing out is an active process where the respiratory muscles, the main being the diaphragm. The diaphragm is this muscle here. Is this the Wesley, where are you? The pointer. So what do I press for the? Sorry. Oh, this one. This one. Yeah. Okay, perfect. So. No, I don't. Oh, it comes. Anyway, you can see the muscle there, which says a diaphragm. It's a big muscle, separates the abdominal cavity from the chest cavity, and normally it is raised up, and when it contracts, it goes down. And the other second muscle which is involved in the inspiration or breathing in is external intercostal muscles, or the muscles which are between the ribs. And when they contract, they expand the chest like a handle of a bucket. So therefore, you're creating when these two muscles are contracting actively, you're creating a negative pressure, and that's how the air goes in your lungs. And when you breathe out, the diaphragm, which was contracted, was down. It comes back to its resting position. The muscles between the ribs, they come back to the resting position. With the result, you breathe out passively, so you don't have to work for it. Muscles are not working, they're coming back to the resting position. And the respiration, I know we've been talking about it, is respiratory center is the main thing. And the respiratory center is affected by multiple factors, some external, such as you're talking of painful stimulation, some joint issues there, and temperature being very high. You touch something, it causes pain, it will increase your respiration. Or you're talking about the exercise, for example, and then the brain, voluntarily you can control your breathing. You can breathe fast, breathe slow, like we were practicing a short time ago. And then, of course, there's some receptors or the structures in the body which are responsive to the chemical changes in the blood, whether it's a carbon dioxide level, oxygen level, or the acidity of the blood, and that can also affect the respiration. So like I was talking about my neck and arm and my fingers and the nail, and that's what I'm going to describe here. So on the top you see there is the windpipe or the trachea is there, which is dividing like a branches of a tree, and as you're going down, at the end, the part of the airways which is encircled by this red square, those are called respiratory zone. So air was traveling from nose, mouth to that place, and it was just being conducted from there to the respiratory zone. So respiratory zone is the one where your blood is separated from the air by a thin membrane. So one side of this membrane is the air, other side is the blood. And what is happening, the oxygen from the air goes into the blood and body produces carbon dioxide. So you're breathing in oxygen and breathing out carbon dioxide. So this air exchange is the main thing, ventilation part. In fact, it's got two things. One, air transport or air reaching there or through this tiny units called alveolus or alveoli. That is called ventilation. That part is the air part, and that oxygen which is going from the blood, from the air to the blood, has to be carried out to the rest of the body, and that is called perfusion. So we have a ventilation and perfusion. So normally there should be a match. Whatever oxygen is going through that oxygen has to be carried out by the blood. So if they're matching with each other, that's called normal ventilation. That's VQ ratio, ventilation perfusion ratio. And if there's a ventilation is a lot of it, but there is no perfusion, so it makes no difference, because the blood can't give oxygen because it's not being carried away. Or the blood is not there to carry the oxygen, again, there will be a mismatch there. So if that's matched or mismatched, those are the two processes there. Again, same thing I was showing before. This is in the black and white, you see the real cast of a normal lung. On the right side, the diaphragmatic representation. And the respiratory zone, I have highlighted by using a green color there. And rest of the airways are the conducting zone. So you're talking, and I'm trying to tell you these normal things because I want to talk about abnormal in a minute. And again, I have tried to give another example, and this is where our patients come. Right side, I have a glove which I inflated, and I've shown the conducting zone by the green arrows there. and the arrow and the fingertips of this glove, which I have colored with the orange color, that's a respiratory zone. So the normal situation, when you have a normal strength of the muscles, respiratory muscles, normal tone of the muscles, you're talking about air going to till the end and coming out. So that's a normal situation. Versus if you have a low tone, that happens in our patient population, and some of them are very, very much hypertonic. Hypo is low. So tone being low, in that case, what happens? These gloves, you see that they're not inflated completely. And some of them tend to collapse also. If they tend to collapse, that means there is no air going. That means there is no ventilation there. And that is basically, and the collapse is called atelectasis. And since it is so tiny that it can't be even seen by conventional X-rays, it's called microatelectasis. And that is the cause of the trouble here. So then we are talking about VQ mismatch, ventilation perfusion mismatch, which we were talking about earlier. Now, here I want to show you how does it happen? How does this low tone in our patient population affect? So here we use a paradigm of a respiratory balance. So you see in the center is the fulcrum, and the thick red line which is showing you the normal situation. And on one side, you have these two components, your breathing pattern and the strength and the tone of the respiratory muscles. And these two combined together called respiratory pump. And this component of this respiratory balance works against the pulmonary mechanics. How supple are your lungs? How easy they are distensible? What is the size of the bronchial tube? Because if the bronchial tubes are narrow, then the air will have more problems. There will be resistance to the flow of the air through those tubes. So the resistance is elevated. If you have inflammation, we'll talk about it in a second, or if a secretions collected there, so again, there will be increased resistance to the flow of air from outside into the place where you want it to be. And then, of course, pulmonary mechanics in terms of, if we're talking about yesterday, scoliosis. Scoliosis is the bend of the spine. So the spine is bent to one side, and it may prevent or the expansion or restrict the expansion of the lung, so called restrictive lung disease. Musculoskeletal disorders, whether it's a kyphosis, means bending forward, sideways, scoliosis. So those things also affect actually. So normally these things are not there. So there is a balance between the two sides, and you have adequate ventilation. But when we talk about our patient here, so we're talking of breathing abnormalities. So if there is an apnea, complete stopping of breathing, there is no air going through. So everything stops. Or there is a hypoventilation. Hypo is low. So there is a very shallow breathing. The reduction in the flow of air into the airways. And that, again, is causing problems there. And if there's an irregular breathing, all those things, we'll be talking a little more about that. And in low tone will affect that. And it's the same thing since some patients, you'll see that they become rigid later on. If that's the case, again, that's going to cause the restriction to the expansion of the lung. If that happens, this arm, the respiratory pump arm, will go up, and at the same time, we'll have the other problems in the airways, which I talked about: inflammation, narrowing, obstruction, pneumonia. All those things are going to cause the other arm going down, and we'll end up with the respiratory insufficiency. And on the left side, you see the clinical phenotype, like what do we see normally in Rett patients, and these are situations like epilepsy, breath holding because of the anxiety or anxiety causing that, and aerophagia or the air swallowing. And we're talking of the obstructive sleep apnea, and we'll talk about in a second, and irregular breathing, cardiorespiratory dysfunction, we talked about it, dissociation or decoupling between the two, and the swallowing issues or the dysphagia. And I want to highlight, and these are affected by multiple factors shown here, but I want to draw your attention to two things here. One is the intermittent hypoxia. All those things are going to cause transient or intermittent lowering of the oxygen at certain times. And then, of course, pulmonary inflammation, and which is being recognized in these patients or any neuromuscular patients basically. And as you know that the inflammation is, people are realizing in so many other disorders here. So I am on one side, you'll see the left side, you have the thick wall because of the inflammation. And you can see the redness there. The caliber of that tube, inflamed tube, is much smaller to the compared to the right side, which is a normal bronchial tube. And what is happening? This is going to contribute to the elevated airway resistance, resistance to the flow of air through this. And moreover, inflammation makes these tubes to be very twitchy, very sensitive. So anything unwanted, like for example, activity or reflux or infection, these tubes are going to be more narrow. So like the asthma patients, and that is asthma is also inflammation. And then again, there is an amount of air which is going through these tubes are going to be less, and ultimately it will be affecting our ventilation perfusion equation, and you'll end up with the chronic respiratory insufficiency or acute also, intermittent, depending upon the situation. Talking about the abnormalities seen in our patient population, we know that whether it's a classical or atypical Rett syndrome, by and large, all patients are going to have the breathing dysfunction at some stage in life. Some of them are very obvious, some of them are very minimal, and some of them are so subtle that conventionally, by observing the patient, we will not be able to see that. And the peak of these problems may be between 6 to 11 years. And then, of course, there is a transient period of 2 years or so when the symptoms tend to get better. And after that, worsening has been noted at some stage in life. And as some of the studies I'm going to show you. And the problems are not present only sleep. They can be present during the wakeful time. In fact, more problems have been reported during the wakeful period, during the daytime. And what kind of problems we are talking about? We're talking about hyperventilation. I'm sure you know about this, increased breathing pattern there, and which may be irregular, episodic, and breath holding, which can be up to 30 to 45 seconds, which is a pretty significant time. And if you try to hold your breath, you'll see that it's pretty significant actually. And apneusis is another kind of breathing abnormality where there is a prolonged inspiration. You're taking a breath in, then the pause, and then short exhalation. And that's called apneustic breathing. That is also maybe seen. And as I mentioned earlier, respiratory abnormalities are seen during sleep as well as during the wakefulness time, and may be associated with low oxygen level. If it is for a long time, we'll call it chronic hypoxia, and resulting in that impaired gas exchange or VQ mismatch, which we talked about earlier. And in addition to that, if the patient is having air swallowing, and that causes the bloating, and that causes discomfort, and that patient may not be able to express that. Or you can see it visually sometimes, and it may not be visible so easily, So those are the things to keep in mind. Other problems which will affect the breathing are sleep disorder breathing. And by sleep disorder breathing, I want to just draw your attention to something here. What happens when there are two stages of sleep. We're talking of non-REM stage. REM stage is rapid eye movement, REM stage, and the non-REM stage, where so REM stage is the time when you tend to be very floppy. You're really floppy. Only two muscles are working that time One was the diaphragm you saw, I talked about earlier for the breathing, and other is the eye muscles. Other muscles are very floppy, and these airways, they tend to collapse. The caliber becomes narrow, and that time you tend to have more problems if there is something because of the Rett syndrome happening there. There's obstruction becomes much more. Apnea becomes much more pronounced that time, and low oxygen becomes more that time. Okay, and so that is seen in some patients. Night laughter, screaming spells, scoliosis we talked about, reflux we talked about. And reflux again, if there's a reflux, you're talking of the gastric contents, because you have windpipe in the front, food pipe in the back, and they are opening the back of the throat. And supposing reflux basically means the stomach contents of the milk or secretion, they're coming back into the food pipe in the back of the throat. Some of it spills into the airways, and the airways go into spasm, and that again causes a reduction to the flow of air which is going into the lungs. And then hypersalivation or the siluria or the drooling can also contribute to that, because some of it, because if there is a problem with the muscles, low tone, that prevents the complete closure of the voice box, like vocal cords. Because normally what happens, vocal cords are away from each other when you're breathing in, so they move away. When you're breathing out, they come back to normal position, so resting position. This is their movement. And when you're eating or drinking, they completely close in order to prevent any food, liquid going into the windpipe. But if there's a low tone or there is a incoordination of these muscles, which is very commonly seen in all the neuromuscular patients, and like we talk about, so that's what's going to happen. Some of the secretions or the drooling secretions or the liquid from the food or the reflux, that's going to trickle down, and it's called microaspiration. So patient may be able to cough it out, and if it's not able to deal with, or if it is going on for a long time, patient gets resistant to that, immune to that, like we say, or used to that. And what happens is going into the lungs, and that's where it's causing the inflammation. And if it's really significant amount and something unwanted food or not, it will cause pneumonia, what we call it aspiration pneumonia. And depending on the baseline health of the lung, it can really cause respiratory failure and need for ventilation, and etc., etc. And then QTC interval we talked about yesterday, and that prolonged QTC, if patient has got a congenital variety, in addition to the drug-induced, that they have been reported to have more breathing abnormalities. So what are the consequences of these pulmonary problems in terms of physiology of the lung? This flow diagram may look very daunting on the first looks, but don't worry, I'm going to break it in components and walk you through this. So basically we are talking of hypotonia, low tone, and as I told you before, in some patients it will be that bad. Some patients will be so subtle, it may be completely absent or very, very little, that which may not be affecting the whole. So don't take it that, oh my God, my child is going to have all this. So you have a low tone, which is causing the restrictive lung disease, VQ mismatch we talked about earlier. And parenchymal disease basically means the parenchyma is the unit where the lungs are working, that VQ, ventilation perfusion is happening. And if that is blocked or infected or whatever, and that is causing the abnormality there, and that is microatelectasis we talked about, and all this is going to lead to the increased work of breathing. And if you have a scoliosis, the sideways bending of the spine, that will also contribute to that increased work of breathing, and eventually we'll end up with the alveolar hypoventilation. Remember we talked about my nail, so the air is not going to that, low ventilation in that part. Okay, now if we add another component to that, which is we talked about the sleep stages, REM stage, being low tone that time, and so we have the low tone and possibility or tendency for collapse of the upper airways. At the same time, we have secretions collected there because your swallowing is not as normal or rather reduced during the sleep, and you have the breathing abnormalities, and all those things are going to contribute to the sleep disordered breathing, and then that is also contributing the alveolar hyperventilation or the low ventilation perfusion. And then of course, if you have this secretion collected there because of the drooling, etc., they are going to collect in the airways, and they're going to cause the airway obstruction, again going to increase the work of breathing. And now if I add the third component, which will be obvious to anybody, and that is the ineffective cough. Because a lot of times you will say, patient come to me, parents will say, my God, he's trying to cough. It's very difficult, and I wish he had or she had a stronger cough so that we can get the secretions. I'll tell you, it was not Rett syndrome. There was a muscular dystrophy patient, and he was adult, and he came to us, and he was having real problems in the coughing issues. He used to ask his father to sit on his chest, though the secretions are squeezed out. So it was so painful to see somebody not knowing what to do with that. And they came from far off place, and we taken care of it. And they said, my God, the device which I'm going to talk, the cough machine, and they said, this is a wonderful thing. Okay. So anyway, so all these things are going to contribute to multiple problems and they are, you're talking of restrictive lung disease we talked about, and then sleep disorder breathing, increased work of breathing, and the alveolar hyperventilation. And all those things combined together are going to cause chronic respiratory insufficiency. Talking about sleep disordered breathing, this was a study of 13 patients. They found 70% of them had snoring. 54% were seen to have apnea. Hyperventilation was present in 100%. And obstructive sleep apnea, 70%. Central obstructive, basically, which we were talking about earlier, a central will be your respiratory center is not sending a signal. That's it. So that I was not breathing that time. Okay, and in that case, the respiratory center will not send the signal. Okay, and then all these are associated with the lowering of the oxygen level, which we measured by this pulse oximeter, and that normal value is 93 to 100%, and these guys noted it to be 88%, and that is not uncommon. And some of the studies I'm going to show you, they had lower than that. And this slide is showing you the importance of abnormal breathing during the wakefulness time, which is very special to the Rett syndrome patient as compared to other disorders, which whether it's a Duchenne muscular dystrophy or spinal muscular atrophy and other problems. Okay, and we talked about the breath holding, and which is basically in this situation, patient takes a breath and fails to release the air, and basically normal breathing, a pause during that time, heart rate decreases, and then the actual breath holding starts and the heart rate starts increasing. Another study, a big number of patients, 228 patients from Claudia Del Felice from Italy, and here I want to highlight the two things. There is something called apnea we talked about. There's a cessation of air or breathing that time. So that's apnea. Hypopnea, reduction in the flow. They took it as 20% or more reduction in the air flow. And they looked at what we do, we call it AHI, apnea hypopnea index. And we look at how many such episodes occur every hour. So the AHI is a number of events per hour, and they saw the obstructive apnea was 6.2%, 6.2 AHI, versus in the wakefulness time it was virtually 3 times, 17.7 versus the 6 there. And that is a very typical feature of Rett syndrome patients. And that has been seen by everybody else, actually, with some of the studies I'm going to show you in a second. So, in summary, these guys found that obstructive episodes were more prevalent. Obstructive episodes were more during the wakefulness time, and the lowest level of oxygen they found was 78.8, and sleep apnea was present in 63%. And AHI in mean population was like a 15.9, but in the patient who had obstructive sleep apnea, naturally more severe problem, there the AHI, the apnea hypopnea index was 27.2%. Another study, again, they found 66 patients and 12.5 years, and 70% had like AHI of greater than 15 and had obstructive apnea, and sleep apnea group had increased AHI, breath holding spells were more, and the lower nadir of the lowering of the pulse ox. Another study, same thing. They found obstructive sleep apnea during the I've highlighted the main findings in the red there, and they found obstructive sleep apnea during the REM stage and the non-REM stage, and which were unrelated to the clinical features, genetics, or stage of the disease. This is a very important statement I'm giving here. So it's not that you have to have a severe problem. You can have obstructive sleep apnea in a milder situation also, and you may not know till you do something about it. And you do something, somebody has to observe them, or somebody has to do proper sleep study to diagnosis. If you don't do it, you don't know. And that is something to keep in mind. And they reported hypoxemia, again, pulse ox readings going to be 81% or so. Now, what is the effect on cough? Before I go that, I want to just briefly tell you how do we cough. Remember, we talked about the vocal cords, abduction, adduction, closing and opening. So when I want to cough, what I do is take a breath in, and the depth of the breath is depending upon my intended effort, how strong I want to be cough. That's what I did. So I opened my vocal cords, filled the air, closed the vocal cords, and started squeezing my lung voluntarily, and which created a kind of pressure gradient. So your vocal cords or the voice box became like a double door, and pressure was building below it. And when the pressure was increasing at a certain stage, it was forcing my vocal cords to open. It's like a double door. It's tight and you're forcing air, you're trying to force it open, and there's some resistance, and suddenly it opens and you fall. And here, this flow of air, which can be pretty significant, and which can be, if I tell you the velocity of that air which comes out in a strong cough has been reported up to 2/3 of the speed of the sound, and the volume which you produce up to like 14 liters, and that creates a shearing force which takes away the secretions which are stuck in the wall of the, so that's your normal coughing. And that coughing, when it is affected, it causes the pooling of the secretions there. Again, aspiration pneumonia, recurrent respiratory infections. We talked about the airway inflammation, bronchial hyperresponsiveness, and eventually can contribute to respiratory failure and need for assisted ventilation. So now, what do we do about it if somebody has got a suboptimal airway clearance? That's where we use this device which is mimicking the cough. In nutshell, what it's doing is it's forcing the air in the lungs and sucking it out. That's it. And so you have this little box there, which was pretty heavy duty, and you're setting the pressure. When you're forcing the air in the lung, what is the pressure you want that time? So you set something. When you're breathing out, machine is sucking the air out of the lung, what should be the pressure? What is the time for the inspiration or breathing in, and what is the time for breathing in out, and how many breaths you are doing? And that machine is attached to the patient by a mask. The tube is coming, your pressures are being generated, negative, positive, transmitted to the tube on the mask. In fact, if the patient is intubated for something, you can attach to the endotracheal tube. If the patient is unfortunate, which is very rare in Rett syndrome, having tracheostomy or the hole in the trachea to ventilate for ventilation, you can be attached to that. But this was the old machine, and the new machine, which is more digital. And so the previous one was like a 28 pounds, excuse my like a system, like we are not metric in America yet, and I'm used to using the pound and not the kilos. So 28 pounds, this is only 8 pounds. And so basically, I'll show you the video. So you have the pressure set there, you see on the blue color and the yellow color. Blue is the inspiration and yellow is the expiration. We are using the machine attached to the mask, and basically it's going in the lung air, now it's coming out in the yellow portion there. Okay. So basically what you're doing is coughing for the patient, and one thing we're doing is measuring also what is the peak flow. Peak flow is the when I cough, what was the height of the flow out of the lung, and that tells you the efficacy of the lung. In order to have a good airway clearance, we have to have at least 160 liters per minute of the airflow. If it is below that, we know that this cough is not effective. In fact, normal is 250 liters. If I do it, I may be 400, 500, 600, depending upon the strength of your muscles, etc. If it is lower, it's going to affect the airway clearance. Okay, and the machine is preventing the lung infection by keeping the lungs clean. Lung recruitment. Remember those two gloves I talked about? And so one was inflated completely. So all the units in the lung were, in that case, was recruited. Air was going in and out. Versus the collapsed portion of the glove, some of the units were not open completely, causing microatelectasis. But if you use this machine, it's going to open those collapsed tubes also, and we call it lung recruitment. And this is another advantage of using this device. Okay, and then of course, when you're forcing air in the lung and sucking it out, you're moving these joints, the rib joints, and that prevents a stiffness. Like any joint, if you're not using it completely, it's likely to be stiff. So that stiffness is prevented. That means the restrictive lung disease is also prevented by using the device. And I talked to you about the cough peak flow. It tells you the efficacy of the cough. Machine measures that actually. Okay, and it can be very gratifying result. Like in this patient who has CDKL5 actually, and I'll play this. Here we had to use a lot of pressure in order to have an effective cough.
You're so used to it, you're not going to be able to beat you at it. Yeah, he kind of sticks his tongue out.
The pressures are 50 breathing in, 50 breathing out. You see the bar is much longer, and you see the mucus plug there. And it is such a gratifying experience. How will this patient cough out this mucus plug which is deep in the lung? And I'll give you an example here. This was a patient who came, and this is a different neuromuscular disorder, but not the Rett syndrome or any associated disorder. And in the lung, air looks black, and if there is no air, it looks white. So you can see the ribs here. This patient has the tube also there, and heart is here, liver below, and what is happening on the left side, you see more whiteness there. So we knew that there is a collapse of lung. We suspected there is mucus plug blocking those airways, and thereby there is a collapse of the lungs. We used the cough machine, and within 2 hours we repeated the chest, because he was clinically she actually was clinically improved significantly. Her oxygen requirement came down and all, and we did the repeat and look at this x-ray. 2 hours difference, and you can see the left side also, you can see the black portion much more. Lungs are much better than what they were before, and this is because of the cough machine. Another component of airway clearance or the getting rid of secretion of the lung is the mucus mobilization. It is like, imagine a ketchup bottle with little ketchup which is at the bottom and which is thicker and stuck there. And you turn it, put it upside down, ketchup is not coming. What do? You shake it, you tap it, thump it, and that's how. And that is the principle here. So mucus mobilization, mucus which is stuck, we mobilize that, and with the result, and after that if we use the cough machine, it helps us to get rid of the secretions. And by and large, it has got 3 components. On the top panel, you'll see there is a machine which is called air pulse generator, and the pulsations from the there are transmitted to this connecting tube, which is connected to this inflatable vest. And what is happening? It is inflating and deflating or shaking like that. If you're doing that machine, and shaking the secretions from there. And you set how many times you want to have this inflation, deflation of this or pulsations there. You decide the pressure, how much pressure you want in order to have an effective system, and then how long you want to do. So usually we do around 20 to 30 minutes each time, and we can have different frequencies, frequency of 10 times per minute to 20 times to 15 times, whichever we decide, depending on the patient to patient. Here is one example, and this is the system. If I can do. Again, same thing. We have the frequency seen there, 10 hertz. Pressure was like a arbitrary scale, 1 to 10 is on 4, and we plan to do it for 20 minutes. The machine is generating the pulsations which are being transmitted to the tubing system. You can see the tube vibrating there, and this is we call it like a wrap around the chest. It's shaking, and some people call it shaker basically. And what you're doing is mobilizing those secretions, and then after this we use the cough assist device, and this is called high frequency chest wall oscillation. Big name, but basically it's mobilizing the secretions. Now, we talked about the low tone, we talked about the muscle weakness maybe in some patients, and we talked about the reduced lung volume, and we talked about the lung recruitment by using the cough machine. But there is another way which is very cheap, very simple. We can use this is called resuscitation bag, this blue color embu bag, and we have a mask and a tube attached to that. And what you're doing is you have the mask on the face, you are inflating the lungs by pressing this inflatable embu bag and expanding the chest, waiting for a few seconds and releasing it. It's like I do in morning my own. When I get up in the morning, one of the exercises which I do in my bed is just building up volume in my lung. I'll hold it and then release it slowly. So what I'm doing, I'm opening those part of the bronchial tubes which were closed when I was sleeping with the low tone, okay? And that's called lung recruitment. And this is a concept which our group has started advising over last 10 years or 15 years. And we had guidelines recently and we included that. And it's a wonderful thing, actually. Other pulmonary abnormalities have been reported in patients which are not usually visible. For example, you have to do the CT scan of the lung, and it has shown, this study, for example, has showed some nodule formation in the lung, bronchial wall thickening, which we talked about earlier, and main thing was here the bronchiectasis. See, there is a tube there in the third picture down below. You see that, no, the top picture, the red color, the bronchial tube is straight. There is no problem. That's a normal bronchial tube. And what is happening? The wall, you have the elastic tissue. And that elastic tissue is keeping those bronchial tube taut nicely. Now, if you have infection, chronic infection there, it causes the inflammation. Inflammation causes the collection of the white blood cells. When they die, they become pus cells, and they release an enzyme called elastase. In medicine, anything ending with ASC, any word, means it's splitting something. Okay, so that elastase digests the elastic tissue which is in the wall of this bronchial tube. The tautness is gone, they balloon up, like in the second picture there down below. And that the secretions get collected there, and they are difficult for the patient to cough out. And moreover, there's a vicious cycle which sets in. You can't cough out the secretions, they are getting infected, more pus is coming, more elastase, neutrophil elastase, the white cell elastase is being released, an enzyme, more digestion or destruction of the bronchial tube, and that causes this bubbling of the airways called bronchiectasis, and that is virtually in a mild form, it's not a big deal, but in a big form, it causes a chronic lung disease, you see, and which affects the functioning of the lung. And what's the cause? Mostly that microaspiration, the coughing, choking, not able to control the secretions in the back of the throat, or the reflux, or the swallowing abnormalities. They can cause aspiration and pneumonia and microaspiration, etc., etc. Other things have been reported in these patients. Interstitial lung disease is another problem. Gas exchange abnormalities, for this example, they have reported in these patients. And respiratory function at some stage, 100 patients, all patients, 228 patients showed moderate to severe problems in 80%, and ventilation perfusion abnormalities we talked about earlier in 80% patients. Swallowing issues, very common problem. In a very, very mild form, in a subtle form, it may not be obvious, or you may see somebody a little bit of coughing when you're feeding or drinking. It may be very obvious. Sometimes you go, oh my God, what's happening? What do I do now? And you're ready to do something, in terms of thumping the chest, etc., etc. So they are seen. And here, when you're eating or drinking, there are three phases. First, you're taking the food in the mouth, you're chewing it, making a bolus, and your tongue and is pushing this bolus into the back of the throat. It's called pharynx, and that is pushing the bolus into the food pipe, and then it goes to the stomach and goes further down for digestion. So that's a normal. And I'm going to show you the possible abnormalities in each stage, actually. So oral phase, the mouth phase, bolus is broken down, food is broken down into the bolus. Your tongue is controlling the movement of this bolus to one side, other side. Then it is pushing the bolus into the back of the throat or the pharynx. and that is affected because of the malalignment of the teeth, which is not uncommon in our patient population. Patient may have difficulty in chewing. Involuntary tongue movements may be there, which are preventing. Tongue mobility may be affected or reduced in some patients, resulting in the poor bolus formation and poor seal in the back of the throat. So it's supposed to be going down, but some of it comes back again. Again, second phase, the pharyngeal phase, back of the throat, poor bolus formation. Again, inability to compress it and push it down. And there may be partial dilatation of the pharynx there. And it takes longer time to go further down. And there may be pharyngeal spill even from the esophagus. Some of it can come back to the, okay. And all these may contribute to the aspiration. In esophagus, in some patients, the waves, the motility waves may be reduced. Thank you very much, Catherine. You are a lifesaver. Thank you. Sensation may be affected in some patients. As you know, some of the patients are intolerant to certain texture. So texture of the food may affect. So all those things are affected. And the top of it, you may have apnea. If the apnea is there, it is affecting that also. And this is all leading to the like a poor like a coordination or the incoordination, and breathing and swallowing are not coordinated, with the result again can lead to aspiration. So on the left, on this side, you have the food pipe shown as esophagus. The big red arrow is showing you the normal passage of the food, which is going to the food pipe and then the stomach. Okay, and you can see the vocal cord. So the vocal cord on the other side, and that is supposed to be closed during that process. And if there is an incompetence there, the liquid, the food is going to go in the wrong way. Okay, and that causes aspiration. And I'm going to show you the video to show that. So here you have a patient is being fed a liquid, barium, which will be shown here as a black. So you see, most of it will be going into the food pipe. The thick column will be going down. Then you'll see, if you carefully, in the front, there'll be a little bit of sliver of like a black color, which is the liquid going to the windpipe. So let's play it. See, now it's the majority of it going into the big. Then you can see in the front, there's a little crescent kind of a dark color, and that's where it goes into the windpipe, and that's aspiration. And you don't know it till you do the swallow study. So the importance is that being aware of those things, and the treating team has to look for them. If you don't look for them, you don't realize that this is going to happen unless some major problems happens. And I've had some major issues where patient landed on the assisted ventilation and respiratory failure, or all kind of things which I don't want to mention, which is uncommon now because people are getting more and more aware of these problems. And if there is a significant problem, somebody having multiple pneumonias, admissions each time, and because of this swallowing problems and the aspiration, then unfortunately we have to switch to these things like a G-tube placement, we call it. So basically what you're using, you're creating a hole in the stomach and putting this tube, and the lower column on the left side shows you it's called G button. So basically a tiny balloon kind of a thing which is inside the stomach, and you have the flap open kind of a opening there, which is used to feed the patient directly. So you are preventing the aspiration. And yes, it is unwanted. Having said, it is a lifesaver, definitely. We talked about the using the cough machine, etc. You're generating pressure. There's a lot of changes in the stomach pressure that time. So, in all honesty, you may be contributing to the reflux that time, in some patients. So, we need to be careful from that point of view also. Sometimes the reflux is so bad that a lot of each time patient is being fed is going to cause reflux and causing aspiration. So there we use this called fundoplication or the Nissen fundoplication. Basically what you're doing is, as you see in the stitch portion of the picture, you bring the back of the this stomach, bring it in the front, and you stitch it there, and you're creating a kind of valve, and which is preventing the reflux from the stomach to the esophagus and then preventing. Then of course it's one side effect is that it may cause more problems in some patients in terms of discomfort, because patient not going to be able to do the belching, for example. Okay? And of course the air swallowing is the issue. So that may also be, so we don't do it routinely. We try to avoid all these interventions, but we decide what is actually needed, and we'll do it if we have to do it. And of course, if the chronic respiratory insufficiency becomes so intolerable and we can't deal with by conventional temporary measures, then we have to think in terms of assisted ventilation. And by and large, our approach is the non-invasive. So invasive is when you create a tracheostomy hole and attach the patient to the ventilator, and that's invasive. Non-invasive is that you're not doing anything, you're using the mask on the face, and that can be, we'll talk about it, different kind of mask, nose, face, mouth, etc. And very rarely, in all honesty, I don't remember deliberately doing a tracheostomy in Rett syndrome in our patient population. No. It has, or if we need it, which is not in all patients, very, very little number, and we have used non-invasive ventilation, and which we have been very successful. And we are like we are a group of 30 people in North America, and we started all these procedure, trying to understand these things since 2002. And since then, we have developed our protocols and we use it, and we publish so many guidelines, statements, etc. The people know what is to be done, and basically non-invasive ventilation is a key thing. We are virtually, I can say that in very rare situation, which I'll talk in a second, we have to go to the tracheostomy, but that is in different disorders, because I deal with all kind of neuromuscular disorders. But definitely non-invasive ventilation has been shown to improve the quality of life, reduce the sleep disordered breathing, reduce those apnea, hypoxia, low oxygen, and elevated carbon dioxide level or hypercarbia, and this is the preferred method. It can be short-term non-invasive ventilation. Supposing somebody is unfortunate enough to have an aspiration pneumonia, respiratory insufficiency, respiratory failure, you put it temporarily for short time, and then patient may recover completely. It may be used in, it's a preferred method anyway. It may be during the procedure. Somebody is having a G-tube placement or some orthopedic procedure, and you may have to use it that time, okay, or G-tube change, and the interface may be face mask, maybe nose mask, maybe face and nose both, or maybe the full face mask. So these are the different kind of interfaces which you can use. Now the modes. What kind of modes we use for the ventilation these patients? Simplest possible is the CPAP. CPAP is continuous positive airway pressure. If you think of it, my arm is in the sleeve of this jacket. If there is no arm, the sleeve will collapse. Okay, but if I blow continuously in that, I'm going to keep that tube open, and that is what is CPAP. Basically, what you have, air flowing into the lungs on a constant pressure all the time and keeping those bronchial tube from collapsing. Okay, so CPAP, simplest form. Having said that, it's not the physiological. When you're breathing in, your pressures are high because remember we talked about the diaphragm or the vertebral muscles, intercostal muscles working, causing a negative pressure. So you got more pressure going in, and breathing out was a passive process. The pressure was low. So that's why we use two pressures. We use one higher for the inspiration, one lower. So BiPAP is called. Bi is 2. The BiPAP pressure, and that can be added with what we call a backup rate. By backup rate, I mean that you have decided, okay, my patient should be breathing for 20 minutes per minute. So ventilator is giving the BiPAP, at the same time monitoring the rate of the breathing. The moment it goes down below 20, it adds one extra. So that's backup rate. So it's not that patient is, let's say somebody is having 45 seconds of apnea. Ventilators like to give the ventilation that time. So you're preventing the lowering of the oxygen during that time. Then this can be triggered by the ventilator or like we talked about, or spontaneously it will be giving. Okay. And we talked about the pressures, inspiration pressure, expiration pressure, how long the TI, inspiratory time, how long you want the air to go into the lung. It's called inspiratory time. Okay. And again, we talked about patient may trigger it or ventilator may trigger it. Other mode, which is called volume assured pressure. So you decide, okay, my patient needs 300 cc of air. So you're telling this ventilator, okay, my finger, upper limit of the pressure, my thumb, lower limit of pressure. So you're telling the ventilator, this is the upper limit, this is the lower limit. You can go beyond this. This is the range. Use this range and provide 300 cc to the ventilator, to the patient. Patient is breathing, let's say patient is able to do only 150. So ventilator is going to add extra pressure to make it 300 each time, but the range of the pressure will be whatever you set there. So you're setting the volume, you're setting the range, and the ventilator is providing. And actually it is called AVAPs, average volume assured pressure support. Pressure support, basically patient is breathing and you are nudging it, you are giving extra pressure to that, and that's called AVAPs device technique. Other technique is intelligent VAPs. There you're deciding how much air should be reaching those alveoli, those units we talked about by nail, and that's called alveolar ventilation. So you tell, okay, I need 6 milliliter of air per minute at that point. And then you have to put the height, weight, and all kind of parameters there in the machine. And it's all intelligence, AI mediated devices. And machine takes care of everything. And basically, but for me, I have used more commonly, all my patients were AVAPs actually. And by the way, this is much better approach for Rett population versus some other neuromuscular disorders, because here you have so much breathing abnormalities, dysautonomia, all those things, irregular dysrhythmias, and the ventilator is, because don't forget about it, ventilator will take care of it. And I have patients who have really were referred to us because they were on the verge of needing a tracheostomy and all, and what can do we? There is no choice, guys. We have to put him on tracheostomy. And no, we were able to manage them in this non-invasive AVAPs mode actually. Then of course, remember, it depends upon the awareness or the expertise of the team, which is interest, awareness, cost, availability of the machine or the devices. So there's so many factors. But at the same time, we are publishing all these things across the world in these journals. People are reading it, and I'm sure it is spreading, and the practices are changing all over. So we talked about the pressure cycle, and there is something called SIMV, synchronized intermittent ventilation. And that is a very simple common form where you are deciding, okay, I want my patient to have 20 breaths per minute. Ventilator will give it, but it will synchronize. When the patient is breathing in, that time is will breathing in for the patient, and otherwise not. So it's a synchronized form, and that's very common mode, and which is not in my in Rett syndrome by and large, that's not my preferred one, but definitely there's another mode. Another mode is so long we were deciding the volume, you can decide the pressure also, and that is more common in premature babies where lungs have a tendency to collapse. The alveoli or the air sacs are not opening, and we use the pressure to keep them open, and that's a different situation. But just to mention that there's another mode there called pressure cycle. Now, as I mentioned, tracheostomy is very rare, and at the same time, there may be a situation where non-invasive ventilation is not going to work. It's not working for whatever reason, because the severity of the problem, low tone, some complications, something like that. So there we may have to consider that. And some patient may have significant aversion to the presence of the mask, which is not uncommon. And if you figure out there is no way I can keep a mask on the face, there is no choice, and patient is landing up in the respiratory failure. So you may have to consider that. And some people prefer, in all honesty. Some people have asked, I'll rather have a tracheostomy here so that I can see my child smiling, child can eat and drink, which is possible even with the tracheostomy, and all those devices which I was talking about, ventilation or the cough machine, that can be easily attached. So there is no forcing air, because naturally that's what you're doing into the mouth and the airways. So the discomfort may be less. So it's a matter of choice. But having said that, with the time, patients tend to get used to it, and you can get away by using only non-invasive ventilation. Another thing which is very important, because I have seen it happening, that patient comes for some common procedure. Patient came for the change of the G-tube and was intubated by the anesthesia and conscious sedation, whatever, and procedure is done. They say, okay, it's fine, take it out. They took it out, but the baseline situation was not normal, and patient landed with a respiratory failure and more problems. And that's why, even if they are intubated for a short time, we suggest don't intubate them the room, don't extubate them, don't take out the tube and leave them alone and just to expect them to recover. Put them on this non-invasive ventilator with a mask for some time till they are really stabilized, when you're sure that the oxygen level, carbon dioxide level in the body are normal, and patient is going to tolerate that. So few extra hours are worth doing in order to prevent any complication there. And then, of course, we suggest start using if the patient has been using the cough machine, start using it as soon as possible. If there is a procedure which was done, let's say scoliosis or something, the control of the pain is a big thing, because that will prevent patient to breathe deeply, so until you control the pain. Other abnormalities which may be seen in this patient, autonomic dysfunction, you heard the talk about that, so I will not go in the details, but in summary, you can have this imbalance between the sympathetic and the parasympathetic system. We talked about yesterday, we talked about this morning, the parasympathetic system being relaxation, and sympathetic system being that acute response to a stress kind of situation. The breathing abnormalities, dysrhythmias, rhythm of the breathing may be abnormal. Temperature dysregulation, we talked about the low temperature in this patient population, and that was a very important point. I don't remember the speaker's name yesterday, that make sure that you know what is normal for your patient. Rett syndrome, low temperature, very common. Say that you take the child to the emergency room or whatever, and they look at, oh, temperature is fine, look at it, it's only 94%. But if you know that your normal is 91 in this patient, so no, it is not normal for this patient. So know the normal temperature for your patient, Sweating abnormalities are there. Cold and blue lower extremities have been observed, we talked about yesterday, and cardiac abnormalities, GI, the gastroesophageal reflux, secondary to the GI motility being low, and leading to constipation, etc. And these are small little things. It's not life-threatening, but it's nice to take care of them, be aware of that, and do something about that. And of course, heart issues may be because of the dysautonomia. We talked about the scoliosis, or the side curvature of the spine, and which has been reported up to majority of the patients, up to 85% of them. And low tone patients can up to 50% may develop during the first year of life. The key thing is that some expert has to keep an eye on that, and if the patient is developing that. And in this study, they showed the 75% developed by the 15 years of age, and if the curvature is more than 40%, we saw yesterday the Cobb angle, etc., and if the 40 degrees or more, you're going to 40 degrees of curvature or more is need for the surgical intervention there. Okay. And patient may develop contractures. We talked about the hip problems yesterday. So those kind of things can be taken care of by surgical intervention by the orthopedic doctors. The point is that it's not one physician, one patient. It's a multidisciplinary approach. You have to involve gastroenterologists. You have to involve respiratory specialists. You have to involve the other sleep specialists in order to have a holistic approach for the care of the patient. Sleep studies, again, if there's an issue in terms of suspicion about the abnormality there, patient may have only difficulty to going to sleep and difficulty in maintaining sleep, and there's some certain reflux or the constipation, air hunger, all those can contribute to the sleep issues. Now the other thing is, which is we are becoming more and more aware of it, and what's the burden of illness? How does it affect? We talked about yesterday also. How does it affect the family? What is the economic or the physical or the emotional stress on the family? So this was a study which we did, and with Walter Kaufman from Boston, and the big names like Ellen Percy and Jeff Newells and all, and we published it came last December. And idea was the burden of illness, and we had 750 patients from multiple countries actually. It was a questionnaire, and idea was to assess the burden of illness in this patient population, and of course it's multifactorial, has a direct or indirect patient on the patient, family, or the caregiver, and in forms of disruption of the daily routine, sleep, social life, need for training to handle the new equipment, techniques, devices, etc. They may have to take day off from the work, and what happens during acute sickness, and how much time do you need to do all this? Like I'm talking of cough assist device taking at least 15 minutes, the other device, the chest wall oscillator, or for 30 minutes. So all that time you are working, you have to do your domestic chores. At the same time, you have to do all these things also. So these are important things actually. And more importantly, you're taking care of one child, and what about the other children? They have to be taken care of by somebody, So this affects, and this is really stressful. We have to be aware of it. What's the cost of taking the child from one place to another place, transport, ambulance, whatever we are doing, and sometimes buying the equipment, or sometimes buying the medications, all those things. So what I have done so far is we talked about the mechanism of normal breathing. We talk about what are the factors which affect that. If the breathing is abnormal, what are the consequences of that? We talked about the breathing abnormalities, and the complications can be seen in patients with Rett syndrome. What are the strategies and techniques used, and what are the comorbidities in these patients? Okay, and I would like to thank the Rett Reverse Foundation, and thank my patient population, who are always the main instigators for my work actually. Thank you very much. And